Fine, sure. Good morning, everybody. I'm Dr. Pankaj Garg, President IIP Delhi for this year, and I welcome you all on this platform of IIP Delhi, in which we are doing e-master class on pediatric cardiology. First of all, foremost, welcome to Dr. Harish Pemde, sir. He is our Vice President of North Zone of Central IIP. Welcome, Dr. Shyam Meena, Secretary of IIP Delhi. The coordinators for pediatric cardiology course, Dr. Neeraj Agarwal, Dr. Mridul Agarwal, who are the pillars of pediatric cardiology at Sir Gangaram Hospital. Chairpersons for the day, Dr. Anil Kumar and Dr. Dhiren Gupta, who are again pediatric intensive care and pediatric cardiology, cardiac intensivist at Gangaram Hospital, and Dr. SAURABH, the speaker for the day. This program has been the most important program of IIP Delhi for last few years. We have been doing various specialty master classes. We have done in field of hematology, neonatology, endocrinology, rheumatology, cardiology, and to make sure that this process continues, the next in line is pediatric intensive care. So that is also being planned, and as soon as we finish pediatric cardiology, we will be ready for e-master class in pediatric intensive care for office-based pediatricians. So this is an initiative so that we keep upright the academic front, we keep on updating ourselves at the cozy environment of home. Though we take away 1 hour of your Sunday time, but that is worth it. After that, you can relax and do your other activities. So for today's session, I request Dr. Harish Pemde sir to say a few words, and then we go ahead. Dr. Pemde sir.
Good morning all. I think IIP Delhi's this Sunday morning program has become very popular and very useful and effective also, as I find that participants are from various parts of the country, and IIP Delhi has become popular for its academics. For the very right reasons, it should be popular, and I am happy that our branch is doing such good activity. Best of luck. Thank you.
Dr. Harish, I can see Amina is busy. So Dr. Smita has joined us after quite some time. Dr. Smita, madam, you are a pediatric cardiology as well as a key member of IIP Delhi. So over to Dr. Smita for a few words.
Dr. Pankaj and Dr. Pemde sir, and speaker for today, Dr. Saurabh, course director, Dr. Mridul and Dr. Neeraj, and our chairperson, Dr. Dheeraj, and Dr. Anil Kumar. So I'm really proud of this activity. I can say I have been chairperson of cardiology chapter for IAP. I worked hard to popularize the cardiology chapter. But nowadays with the Zoom and the online meeting and Dr. Pankaj Garg at the helm, I am really finding him very dynamic, and he's everywhere and always for the cause of health. It may be exercise, it may be a better living lifestyle, and it may be academics, everything top class. So I really congratulate the IAP Delhi for its really great work. And all the master classes are really great subject chosen, the speakers and the person who are, and Dr. Neeraj, I know him for such a long time now. He's taking over the cardiology chapter as a secretary, which is now National Pediatric and Fetal and Pediatric Cardiology Forum, which I registered in my tenure. So thank you so much for calling me and giving me this chance. I hope I'm not very long. Thank you so much.
Okay. Dr. Shyam Meena, Secretary IIP Delhi.
हाँ डॉक्टर मीना को तो मैं भूल ही नहीं सकती हूँ. एक्चुअली जब भी मुझे बात करना होता है दिल्ली आईएपी में तो सिर्फ डॉक्टर मीना ही होते हैं. बट just I forgotten because it was a extempore. Dr. Meena, I'm extremely sorry not taking your name. You are the first person for Delhi IAP in my heart and my brain. Okay.
I think our time is over. We can start the answer already.
Yes.
Right. So,
and he is a military person on time. Nahi, Meena is very particular about time.
So over to Dr. Mridul Agarwal for introduction of the chairpersons of the day, Dr. Dhiren Gupta, Dr. Anil Kumar, and the speaker, Dr. Saurabh. Over to Dr. Mridul Agarwal, sir.
Good morning, everyone. So, chairperson, today's topic is supposed to LV dysfunction in children. and chairperson for the day is Dr. Dhiren Gupta. He is in charge of pediatric intensive care at Sargangaram Hospital, and he is practically a teaching force in Gangaram. He is teaching all the time, all the meeting, and he's the one person who's popularized the focus and detection of LV dysfunction at the bedside, and he was at the helm of the thing when COVID happens and a lot of LV dysfunction was happening, and he developed the protocol and managed the patients well. So welcome, Dr. Dhiren Gupta. And the other chairperson is Dr. Anil. He is in charge of pediatric cardiac intensive care at Sargangaram Hospital, and he has a very different perspective because the LV dysfunction in post-operative period has a very different approach, and he manages a very different level. The role of inotropes are different, the calculations are different, the approach is different. So welcome, Dr. Anil. We really will be helpful to have an input from you. And Dr. SAURABH, speaker of the day, he's the professor at Professor of Pediatric Cardiology at All India Institute of Medical Sciences, Delhi. And he has a very good teacher. We have the privilege to listen to lot of his lectures and talks at various places. And he has more than 160 publications at various high-index journals, internationally and nationally. And he was a part of Panorama trial also, which was Army trial for in pediatric in India. So he has a very good insight into management of heart failure and LV dysfunction. Welcome, Dr. SAURABH. And now I think we can start with the talk, please.
Before we start, over to Dr. Dhiren Gupta for a few words of encouragement. Dr. Dhiren, sir.
Good morning. Good morning. Sorry, I joined a little late, and I think today's topic is very, very important, and especially with the advent of focus, we are able to diagnose ventricular dysfunction. I remember in 1997 when I joined Gangaram, we used to give fluid, and in many of almost 50% of the patient, there used to be ventricular dysfunction, right? And later on, once patient collapses completely, then we used to diagnose, okay, it is ventricular dysfunction. And there used to be around 6 to 8, 10 hours gap for an cardiologist to appear and do an echo. And that time means we didn't have Dr. Midul, Dr. Neeraj, and we were fortunate enough that they taught us about focus and how to do echo. And later on, we found that they were helping themselves so that they did not to come. And we are now fortunate that each and every fellow is able to diagnose not only just ventricular dysfunction, about systemic vascular resistance and so many things. So probably, jokes apart, the focus has changed the entire scenario. It has revolutionized everything in managing the patient. And we were fortunate to have fellows like Dr. Anil. We are proud to say that Dr. Anil is one of the fellow who passed from our ICU. Then he is doing that work that is, very rare. That is pure cardiology, pure cardiac intensive care. And it's very difficult, but he's doing amazing job, and they have got amazing unit. So with this word, I leave it to Dr. SAURABH and for today's topic, which is very important, ventricular dysfunction.
Dhiren, a few words from Dr. Anil also as a chairperson. Dr. Anil.
Yeah. Oh, thank you, sir. Good morning to my seniors, particularly Pemde sir. I have been Kalavati previously also, Smita ma'am, Pankaj sir, and Neeraj sir, and Dhiren sir. So as sir has already talked that I have been trained in Gangaram only, and sir is my mentor, Dhiren sir is my mentor. I thanks my senior to make me a part of this academic activity. And as sir has rightly said that ventricular dysfunction, particularly in patient who doesn't have any congenital heart disease, is often unrecognized or under-recognized, particularly right ventricular dysfunction. So as focus is more becoming a part of intensive care, it is very, very, I think it's a great time to discuss this topic to target the ventricular dysfunction in these patients. Not wasting time, I request SAURABH sir to start the session. Thank you very much.
So SAURABH sir, please start sharing your slides and we can start the presentation. Yeah, it's all.
Good morning, everyone. I think you can see my slides now. Is it visible?
Yes.
Yes,
Okay.
yes. Go ahead.
Okay. So, as you would see through the presentation, that after thinking through a lot, I realized that I probably will be better if I kind of tweak the presentation a bit. I'm sorry if it is slightly different than what is expected out of me for today, but I hope that it will still be useful for the most of the attendees who are in the session. I respect all seniors and everybody who has given me this chance, and especially Neeraj, who has allowed me to share my thoughts in this session. So, if I start, I would like to first ask, what is the thought about this question? We have to choose one of these. So if somebody wants to answer in the chat box, we'll be fine. That will, kind of generate the context. If not, then I'll move ahead. So heart failure is equal to ventricular dysfunction, or heart failure may not be equal to ventricular dysfunction, which means to say, is heart failure always because of ventricular dysfunction, or can it be without ventricular dysfunction is the question. Now that is the next question. Ventricular dysfunction is always related with heart disease, or can ventricular dysfunction be there without heart disease? Now, I think as the context has been set, most of the time we think that the heart failure may be related to ventricular dysfunction, but it becomes obvious that it's not so. And many times we get heart failure without ventricular dysfunction. So now this was the topic that was given to me, approach to suspected ventricular dysfunction, and I thought about it. And what I came up is that this is the spread of heart failure in pediatric population. And if you see carefully, ventricular dysfunction is making almost like this 15%, and rest is related to many other diseases. So I thought that if I focus more on heart failure, it will probably do more justice to these 45 minutes, which we'll have. So I'll give this overview. I'm currently the professor of cardiology at AIIMS New Delhi, basically a pediatrician who is trained in cardiology. So my talk is more tailored to thinking what I would think as a pediatrician if I'm not so much aware about cardiology. I know many of the people who are into practice in intensive care and cardiac units may be knowing much more than what this presentation may give, but still, to serve to the majority of people in the attending group, I have focused on this. Now, this was the cardiac failure in children long back when there were no medications available, nothing was available, and today we are talking about focus. And here you can see the only treatment was this bed position, which was offered to these patients. Now, before we go anywhere further, we have to understand what is heart failure. And this is the classic definition of heart failure, which is given in our MBBS books also. And it says that it is inability of the heart to pump oxygenated blood sufficient to meet the metabolic demands of the body, and or does so at elevated filling pressures. Now, this is a very theoretical definition. It doesn't tell us what happens to these patients. And therefore, this definition has further been expanded. And it now includes that it can be because of cardiovascular diseases, or it can be because of non-cardiovascular abnormalities. Along with cardiac abnormalities, it is a full clinical syndrome, which is accompanied by many circulatory changes, neurohormonal changes, and molecular derangements. Now, this is very, very important to understand because the treatment also lies on the same principles. Once we understand that the heart failure is not only cardiac abnormality, it also involves a lot of neurohormonal changes. And that is true also for ventricular dysfunction. Now, when we treat ventricular dysfunction or heart failure, we are not actually treating the ventricle itself. We are treating the whole lot of presentation that is happening in and around that. Now, this is the etiological, epidemiological data about heart failure. As you can see, a lot of patients are now being admitted with heart failure, especially because congenital heart disease, unrepaired and repaired, are increasing in number world over, and these data are from West. We don't have our own data to say what exactly it may be. Now, these are various etiologies. Now, if you go and focus on this, as you can see, ventricular dysfunction is making only this part. Rest is related to cardiomyopathy, secondary cardiomyopathy, congenital heart diseases, and congenital heart diseases make a large chunk of heart failure patients. Also, I would like to focus here that there are a lot of conditions which are non-cardiac, and they may also cause heart failure, like anemia, thyrotoxicosis, systemic AV fistula, and many others like storage disorders. Now, I think here is this is what I think our job as a specialist is, to bring these things to attention to the pediatricians who are managing some of these patients. And once we diagnose them, treatments are possible. And that is why we need to know that ventricular dysfunction is only one part of heart failure. Heart failure includes many other conditions. And once we can define the etiology, we can treat, and these patients can be improved. Now, this slide I've already shared. Almost 2/3 of the heart failure in pediatric population is because of congenital heart disease. A good chunk, almost 14%, is because of arrhythmias, 13% is cardiomyopathy, 2% is myocarditis, and 18% would be others that would include non-cardiac causes as well. Now here, if you can see, congenital heart disease should be treatable. Most of them should be treatable. Arrhythmias also are easy to treat in most of the conditions. So a large chunk of these patients are treatable heart failure. If not completely cured, they can be controlled on medications. Now, it is very important to define what is the cause of heart failure. And when it comes to that, age is very important. And I think nobody knows better than you people that age is not just a number. Everything changes with age. If the patient is a neonate, the etiology is different. If it is an infant, etiology is different. And I think I would like to focus over here metabolic causes like hypocalcemia and vitamin D deficiency, which is very easily diagnosable, very easily treatable, and the results are very rewarding. When it comes to children and adolescents, the set of conditions which are causing ventricular dysfunction is different. And we'll dwell upon some bit of it in the subsequent slides. Now, before we go on to understand how heart failure can be managed, we have to understand that there are changes in the heart, which leads to stretching of the cardiac myocytes, and there is change in the fluid volume hemostasis that leads to activation of the renin-angiotensin system, that further leads to increase in the vasoconstriction, fluid retention, sympathetic overactivity. There are also changes into natriuretic peptide system, which leads to vasodilatation. So there is a balance between which is deranged in heart failure. And overall, once the disease is in the heart or otherwise, the initial pathology maybe is in the heart, but overall, later on, it is not simply localized to heart, and it is a disease of the whole body, especially the renin-angiotensin system. And this is very important because these are the targets which we'll be using for treatment of these patients. Now, these are some of the terminologies, and I think this was the second question which I asked. Heart failure is not always because of ventricular dysfunction. It may be because of other conditions where heart function is normal. So heart failure can be because of systolic heart failure when the ejection fraction is reduced. It can be diastolic heart failure when the ejection fraction is normal. It can be high output failure where cardiac function is normal, both systolic as well as diastolic, but the blood through the heart is more, so there is fluid retention, and therefore there is manifestation of heart failure, like in conditions of thyrotoxicosis, beriberi, and anemia. Compensated heart failure is more technical term in terms of management, whether this patient is having end organ perfusion abnormality or not. And decompensated are those where the patient is likely to require support to maintain the end organ perfusion. Advanced heart failure is the one where without inotropic support, patient is not going to maintain the blood pressure and other hemodynamic parameters.
Sir, I can interrupt you for a second.
Yeah, Neeraj. Yes.
So for the last slide, sir, can we go to the last slide? Sorry.
Okay. No problem.
This okay. So a lot of times questions are asked, when do you say shock in this scenario? I say heart failure versus shock. So a lot of times questions are asked, when do I say the child is shock versus heart failure? So that is one question. Second is, how many times you see diastolic heart failure in your practice in pediatrics, basically?
So, very, very important question. I was trying to tackle them later, but we'll discuss it here. So, one, heart failure is not synonymous with shock. Patient can have heart failure without shock. Shock is a condition when the end organ perfusion is not met. It can be easily measured by the blood pressure, but that is not the only criteria. For ease of terminology, shock is diagnosed when the blood pressure is less than fifth centile for the age and weight appropriate nomograms. But shock is also present when BP is maintained but end organ perfusion is not met. Heart failure, on the other hand, can be there without shock. Like, for example, a patient of VSD who has tachypnea, tachycardia, poor weight gain is also in chronic heart failure while patient is not actually in shock. Now, coming to diastolic heart failure, this is very less common in children, especially because the ventricles are compliant, but that also may be seen in conditions like restrictive cardiomyopathy, those conditions where the patient have received a lot of blood transfusion, like in thalassemia, and some of the genetic conditions where there is restriction because of HCM, like in Noonan syndrome, or other forms of HCM or glycogen storage disorder, where the patient may be having diastolic heart failure. Is that okay, Neeraj?
Yes, yes, sir. Thank you, sir.
Okay, so we'll go ahead. Now, I think symptoms are very well known. I would not like to spend time here, but just what I want to say, that in a neonate and infant, as we know from our background medicine knowledge, that heart failure, one of the manifestation is breathlessness on exertion. Now, for a neonate and infant, feeding is the only activity. So suck rest suck cycle is nothing but an equivalent of dyspnea on exertion. Now, since they have lot more metabolism, or rather heart failure is a catabolic state, then because of that, even if the nutrition is good, the patient is having poor weight gain. So a poor weight gain in a patient with heart failure is because of two reasons. Number one, poor feeding, secondary to breathlessness during feeding, and second, because of catabolic state, and that leads to failure to thrive. Among the signs, I again want to emphasize that unlike the traditional signs which we are taught in our MBBS and initial MD days, the raised JVP, edema may not be the signs which are seen in young infants and young children. However, hepatomegaly is a consistent sign which can be seen in a patient with heart failure. So if you are having a patient who is having suspicion of heart failure, do not look for JVP. It's unlikely to be there. Do not think that you will get edema in a child. It's very uncommon to have edema. On the other hand, hepatomegaly is a very consistent sign. And if you want to be more sensitive in picking, tachycardia and tachypnea are the ones which should give the earliest marker of possible heart failure in any given patient. ADHF, acute decompensated heart failure, is slightly different condition. And I think the focus should be different if we want to talk about that. Today, I want to focus on kind of a chronic heart failure, because I think that is more dealt by the pediatrician without the help of cardiologists or sometimes under supervision. Now, important points to understand is whenever you have a patient who is having suspected to heart failure, always check all the pulses and blood pressure. Any pulse discrepancy, any blood pressure discrepancy should lead us to suspect that there is a problem in the arterial system, precisely to say it can be coarctation of aorta. And second possibility we must not forget is aortoarteritis or Takayasu's arteritis. And I can tell you from our own experience that we still keep seeing at least 2 to 3 cases of aortoarteritis who are undetected simply because pulses have not been checked, or coarctation are missed because pulses are not being checked. Now, next is left to right shunt establishes at around 6 weeks of life. So even if there was a VSD at birth, the shunt establishes at 6 weeks, So 3 to 4 months is the time when the patient is going to become symptomatic, even if there was a disease beforehand. Usually, we think that cyanotic CSD with decreased pulmonary blood flow like TOF is a reduced pulmonary blood flow situation and there is no heart failure, but that's not true. These patients also can have a heart failure if they have associated anemia, infective endocarditis, hypertension, aortic regurgitation, or chronic cyanosis, which can lead to ventricular dysfunction. So in effect, if I have to say in one line, heart failure can exist in almost all congenital heart diseases if they are not treated in time. Now, some of the conditions which can lead to heart failure secondary to ventricular dysfunction can be just like a clinical spotter. So if you see a patient who has these woolly hairs, palmoplantar keratosis, then you can, and there is a family history, you can make a diagnosis of genetic cardiomyopathy. In this case, it is Nexus disease. So that emphasize the importance of clinical evaluation, dysmorphic analysis, because many of these cardiomyopathies in children is secondary to genetic abnormalities. Now, when we talk about these patients, how do we manage? So management depends upon how severe is the disease, how difficult it is for the patient's hemodynamics. So we have to see that the NYHA classification, which is generally used, is not suitable for children. It is suitable only for children more than 6 years of age. And therefore, I would urge all the people who are here to understand that there is a separate classification for staging or functional staging of heart failure, and that is modified Ross classification. And I think we should adopt it more and more. It is almost the same, but it is more age appropriate for these children. Now, this is staging. For the timing, I'll leave it, but it just says that once the patient goes to higher stages, it means that patient is sicker than the previous stage. Now, this is the next question. Chest X-ray, no cardiomegaly, no heart failure, cardiomegaly, heart failure. Not kind of question, but what do you think about it? Any responses until that time? If we have to dwell on something else, Neeraj, we can think about it.
Sir, Saurabh sir. So there is a question in the question box. Why not edema in pediatrics? Why not edema in common in pediatrics?
Yeah. So I think there are no specific descriptions given why there is no edema, but I think it is related to the integrity of the capillaries, that there is no capillary leakage, and secondly, they do not have so much of fluid retention by the time they become symptomatic. There are more symptoms which come up earlier and they reach to us earlier. On the other hand, in elderly and adults, I think it is the capillary integrity which is not so good and fluid retention is much more, and that is why there is edema in these patients.
So for this question, we can take the opinion from chairperson, Dr. DYSFUNCTION sir, Dr. Anil. What is your opinions on this question? Because panelists can speak actually in the.
Yes.
For me, I think cardiomegaly is mostly there with the heart failure. It's unlikely to have a no cardiomegaly and heart failure. It's very unlikely. So I personally think that cardiomegaly is almost always there with the heart failure. It's rare to have no cardiomegaly, no heart failure. But I can't be 100% sure. Dr. DYSFUNCTION sir, what is your opinion about this?
I think as in because we deal with normal patient landing in myocarditis, most of these patients might not have time to develop cardiomegaly. So these patients, I say that almost 1/3 of the patient with myocarditis doesn't have cardiomegaly at all. So probably it is a time duration which is required for cardiomegaly to develop, and sometimes it is acute decompensation. These patients might not develop cardiomegaly.
Yes.
Yes, I would agree to same conclusion. Yes, we often see cardiomegaly with heart failure, but it's not essential to find cardiomegaly with heart failure.
So I think that was the point of bringing this point here, that we generally think that if there is cardiomegaly, it should be synonymous with heart failure. But as has been alluded very nicely by both the panelists, that heart failure can exist with normal heart. in acquired heart diseases like myocarditis, it probably indicate the severity of the duration of illness. On the other hand, some of the conditions like aortic stenosis, there can be heart failure without cardiomegaly. In neonates, there can be TAPVC without cardiomegaly, and still the patient can be in heart failure. So I think cardiomegaly is not mandatory. However, having said that, if you talk about the cardiomegaly, status of cardiomegaly in chronic heart failure, then absence of cardiomegaly practically rules out a significant heart failure in any given patient. So as you can see over here, except in conditions like obstructed TAPVC, RCM, in neonates also, even if the heart disease is there, there needs to be a time for the heart to enlarge. If you see a significant heart disease also in a neonate, you may not get all the signs on X-ray, and therefore there may not be cardiomegaly in these patients. Now, some of the classical X-rays, I'm sure this is known to most of the people sitting here. TGA, which gives rise agons end appearance, truncus arteriosus, it gives increased pulmonary blood flow, and supracardiac TAPVC. However, none of these signs may be are so sacrosanct about the disease because they may not be present in early neonatal period. And on the other hand, thymic shadow may confuse us sometime with cardiomegaly because it can appear almost in any shape and size. Now, I think ECG is very important. And I would like to spend 30, 40 seconds over here because many conditions which comes with heart failure, even with ventricular dysfunction, can be diagnosed on ECG itself. Tachycardiomyopathy is one condition where there is abnormal rhythm, heart rate is fast, and because of persistence of tachycardia, there is ventricular dysfunction. It can also be because of bradyarrhythmia like CHB. It can also indicate and give a clue towards L kappa, which is anomalous left coronary artery from pulmonary artery, where you would see signs of ischemia in the lateral precordial leads like lead 1, AVL, and V5, V6. Prolonged QT, unlike what we think that prolonged QT can only be because of long QT syndrome, it can also be a representation of hypocalcemia and vitamin D deficiency, and can be easily detected on ECG and can be treated if you are suspecting heart failure in a patient. Decreased QRS voltage can be a sign of myocarditis or hypothyroidism or pericardial effusion, and biatrial enlargement, if it is present, then it can show RCM. So ECG provides a lot of clues and it is easily available to almost everyone. I think ECG is something where a lot of us do not pay attention to during pediatrics, but through this session, I would urge that I think if there are postgraduates, that you should learn to read ECG because not every time cardiologist is available. And if you make a provisional diagnosis, it helps the early management of these cases. So here, as you can see, P rate is much more than the QRS rate. There is no relation of P with the QRS. P is coming on its own, QRS is coming on its own, and it is AV dissociation, complete heart block. If you treat with pacemaker, these patients are going to be treated. Now, this is Q wave in the lateral leads. With tachycardia, a patient who is an infant with heart failure, and this is the ECG, L kappa is the most likely diagnosis. Even if the echo is not showing, it means that echo person is not trained in echocardiography, and you still should be asking for a detailed analysis of coronary. So much is the accuracy of these signs. And it has happened even at our center that echo was defined as normal. But since the SCG was showing this, we went back and said that this echo is not okay. And we picked up this L kappa, and this is a treatable condition again.
Saurabh sir,
Yeah.
about the kappa ECG, Dr. Dhiren has seen these patients in our unit also, that our fellows first pick up the ECG in all LV dysfunction. Now, Dr. Dhiren is around, I think he can vouch for this. They do the protocol of focus, they see the LV dysfunction, and then they do the ECG, and then say though they know kappa on ECG. They're so trained. So this concept has been ingrained by Dr. Dhiren Gupta and team, the chief intensivist, into the fellows. Dr. Dhiren sir, what do you think about this ECG? Dhiren sir?
Yeah. Actually, what I liked about the talk is comprehensiveness, right? And it is very simple way Dr. Saurabh is teaching us, and this is the way one should have good approach, right? Like he started with the pulses, and then not only just echocardiography, also ECG. So these are the points which normally young enthusiastic intensivists tend to miss. They just focus on focus, right? They have done focus, they so got so enthusiastic, sir, वो तो left ventricular dysfunction बिल्कुल normal है, right? Oh, sorry, left ventricular function बिल्कुल normal है, and they don't look at the ECG. And I again vouch for you, Neeraj, that you have taught us, and it has helped immensely to all of us, and to have an approach. So, in general, approach should be correct. You are not going to miss, and everybody has learned by doing mistakes. So it's better to learn from others' mistakes rather than doing again the same mistake.
Thank you, sir. Saurabh, sir, do you think ECG can be normal also in Al-Kappa? Like, sometimes I have
Yeah,
seen this.
there was one
Yeah.
patient, if you remember, Neeraj, there was a patient who presented with the respiratory distress, right? And there the ECG was normal, and you picked up some abnormal signal from the posterior wall of the left ventricle, and you spent 45 minutes. There was the normal ECG in that patient,
Yes.
and then you got an MRI later on. And I still cannot forget that the child is now 6 year old and absolutely fine. So I mean to say, in general approach, and what Dr. Saurabh said, that is a trained echocardiologist. Even if we are doing focus, that should not be a final end. It should be referred to a trained cardiologist who can find much more than a person who is just focus on focus, right? So that is very important.
Saurabh, sir.
So I think it's a very great discussion we are having, and I think that is a very purpose of such sessions, because I think we can't cover topics by topics in 1 hour or something. I think it's more about developing an analytical mind, because once we have that, we can deal with any topic as such. Now, coming back to normal ECG in Al-Kappa, I think it can happen early in the disease when the child is less than 6 months, 6 weeks or 2 months, because again, Al-Kappa, the pathology is because of coronary steal, and that will set in once the pulmonary vascular resistance goes down. It will not set in before that. So if you see a patient who is L-Kappa who has incidentally come because of something else, less than 2 months of age, you can only pick by echo. It won't be possible to pick on ECG. Other conditions, wherever there is increase in the pulmonary artery pressure, like if there is associated VSD or any other condition which is causing PAH, you may not find coronary steal, and therefore there may not be a feature of ECG or coronary abnormality on ECG. I think for the sake of time, we'll go ahead.
Sure, sir.
And yeah, Neeraj, you are saying something?
No, sure, sir. Please go
Yeah.
on.
So now this is one ECG. This is a very typically seen that this is an abnormal ECG. And as we can see, the heart rate is quite fast. It's more like 150 or so. And we can see that there are no discernible PV, but there is just undulating motion. And if this rhythm persists, it can lead to ventricular dysfunction and heart failure. Now, why it is important to understand that this ECG is giving immense clues to us that this is actually a flutter where you just cardiovert and this patient is going to become normal. In most scenarios, you are not going to require anything beyond that. A simple cardioversion with 0.5 joule per kg is going to treat this patient with actually no follow-up treatment, especially if it is an infant where there is no structural heart disease. Now, sometimes that tachycardia is not so prominent. Here, as you can make a diagnosis of flutter, which is easy. Sometimes it is ectopic atrial tachycardia, and I can tell again from my experience, and I think Dr. Dhiren can verify that many a times patient comes with documented heart failure from elsewhere, being treated for heart failure, and what is missed is that subtle change in the P wave axis with tachycardia. So tachycardia is a sign of heart failure because heart failure compensation happens with tachycardia. But tachycardia can be the cause of heart failure. And we have to learn to differentiate between the two. If the tachycardia is the cause of heart failure, treating that tachycardia is going to give us rewarding results. Now, this is hypocalcemia. Again, if you have documented echo which shows LV dysfunction and there is long QT, and this is a child who is an infant who is predominantly on cow's milk, mother is frail, nutritionally deficient, the diagnosis is hypocalcemia, and again it is perfectly treatable. There is no further treatment required. 100% recovery of ventricular dysfunction. Now, this is electrical alternance, more like heart failure in emergency situation, where if the QRS axis is changing, QRS height is changing, you should be thinking of pericardial effusion. I'm sure in OPD practice it would be seen less, but in institutional practice it would be seen more. Now, what is the role of ECG in myocarditis? I think we keep thinking that myocarditis can be diagnosed only on echo, but I can tell you, myocarditis doesn't show anything on echo other than global ventricular dysfunction with no regional wall motion abnormality. There are no much signs on echo, but ECG gives us a lot of clues by prolonged QT, non-specific STT changes, tachycardia, and sometimes there can be ST elevation or depression in these patients. And if you are seeing in a patient who has had recent worsening or recent onset of heart failure, you should be thinking of myocarditis. Now, having said that, echo is the central imaging modality for diagnosis of ventricular dysfunction and heart failure. As you can see over in this patient, there is hardly a movement of the ventricular wall. This is dilated left ventricle. This is left atrium, and there is hardly a motion. So there is all the chambers of the heart, all the walls of the left ventricle are having reduced motion, and that is what we call as global hypokinesia, leading on to significant ventricular dysfunction. Now, depending upon the etiology, you will treat the patient. Now, what all comes to our mind is the question when we treat these patients. Now, this ventricular dysfunction can be because of afterload, where it can be because of LVOT obstruction, where there is aortic stenosis causing obstruction to the outflow of the left ventricle. It can also be because of coarctation in a young child and an infant, where there is increase in the afterload in these patients. It can also be because of myocarditis, and it can also be because of genetic dilated cardiomyopathy. So the etiology can be any, and all of these can give this appearance. There are certain pathologies which will give distinctive appearance, like left ventricular non-compaction. Now, L-kappa is one favorite condition which we always like to talk about, because this is treatable, surgically treatable condition, where, as you can see, this is the pulmonary artery, this is the aorta, and this is the left coronary artery, which is stealing blood and going into the pulmonary artery. This left coronary artery was supposed to get attached over here into the aorta, and was supposed to get this blood from here to here, but instead, this is giving blood to the pulmonary artery, and therefore there is reversal of flow from the coronary artery, from the myocardium into the pulmonary artery. And again, once you diagnose it in time, patient can be completely cured. And why it is important to pick them early? Because it has been shown that if these patients are treated after 7 months, they will have residual ventricular dysfunctions and outcome may not be as good. Now, some of the other conditions which can cause heart failure can be diagnosed also on echo. As you can see, there is a large mass in the pericardium. This can be picked even on fetal echo. And once you treat them with appropriate therapy, like in this case, this was rhabdomyoma, and we gave sirolimus, and this tumor disappeared, and the patient became normal. So this is the beauty of stepwise analysis, that you identify the disease and treat them accordingly. This is Pompe's disease. How do you diagnose? You look at the echo, which shows global concentric LVH, and in addition, there is PR shortening, and you think of Pompe's disease. Again, you can think of giving enzyme replacement, and these patients can be treated. Now, these are some of the standard like VSD, where once you diagnose VSD, patient is in heart failure, you can treat. And this is one example where left ventricular function is normal, perfectly normal ventricular function, despite that patient is in heart failure. and the treatment is VSD. If you don't treat that, howsoever medications you give, you are not going to treat these patients. Now, this was Pompey's ECG. I think there was some misplacement. I would just like to highlight that this is the PR, which is very short. So if you see a patient of heart failure, especially in infancy, patient has very high voltages in the QRS, in the precordial leads, along with the short PR. Think about Pompey's disease. Echo also shows concentric LVH. Even if it is not coming from a trained pediatric cardiologist, it should mean that you are dealing with Pompey's disease. Shall we move ahead, Neeraj?
Yes, sir. Yes, sir. Keep on, please. Please.
So these are other investigations, like as we have repeatedly emphasized, we have to look at anemia, calcium, and other things. Now, other are the cardiac biomarkers. Now, I would like to highlight that troponin is something which gives us marker of cardiac muscle injury. So if it is elevated, it can give us a clue that the disease may be recent onset, like myocarditis or inflammatory myocarditis. And I'll tell why it is important, because the therapy also depends whether it is an acute phase or not so acute phase. Anti-proBNP, these are markers of the severity of heart failure, and they may not directly indicate the acuteness of the illness. So troponin is telling us the acuteness. If it is elevated, it may indicate that it is acute in onset problem. Anti-proBNP is telling us about the severity of the heart failure or the amount of fluid overload a patient is having. Now, these are some of the conditions where our echocardiography may not completely pick the diagnosis, like patient is in heart failure, is having breathlessness, disproportionate right-sided ventricular failure, and the patient is actually having pulmonary thromboembolism. So there comes the role of advanced imaging. Now, this is another example. This patient is having double aortic arch, where there is compression on the airway. Patient is having PAH because of that compression, and this patient is having heart failure because of right-sided dysfunction. So some of these things can be diagnosed on CT. MRI also has a role, but I would say that for majority of cases of pediatric heart failure, ECG, X-ray, and echo is sufficient. Only 5% or less than that percent patients would require MRI, but MRI gives us a lot of clues about if it is inflammatory myocarditis, inflammatory cardiomyopathy, or there is a tumor where MRI can be used to characterize the tumor, based on which we can treat these patients. Now, coming to the management. Now, as I have purposefully skipped acute decompensated heart failure, but if it is there, we have to first assess and treat the hemodynamics. And then the first and foremost goal should be to identify the etiology, because once we identify that, the treatment becomes easy. You also identify the precipitating factors. For example, a patient of TOF may be in heart failure, not because of TOF, but because of anemia or because of infection. If you treat that factor, you come back to your baseline state, and then you can treat the etiology or the underlying heart disease at ease. Treat the cause if possible. Like, for example, if there is aortic stenosis, you can't treat heart failure without relieving the aortic stenosis. And if it's still there, heart failure, then you manage with medications. Now, these are the goals. You want to improve the hemodynamics. You want to prevent the progression. You want to reduce the mortality and readmission. At the same time, you want to improve the growth and development. Now, these are some of the treatments which we can offer in our cath lab. So this is like VSD device closure, PDA device closure, PDA device closure in a preterm. All these can take care of heart failure in these patients. Sometimes we can even treat this critical pulmonary stenosis or pulmonary atresia, where the patient is going to be in gross heart failure. We have to open this channel, this pulmonary valve, and do a balloon dilatation. And all this can be done once we make the diagnosis. So the composite diagnosis is important. Now, there can be a case where the diagnosis etiology is not treatable surgically or catheter based. Then we need to target these various parameters to optimize the hemodynamics. So you can optimize preload, you can optimize afterload, you can change the contractility, you can change the heart rate, and the final outcome is the cardiac output. Now, I am sure with the likes of Dr. Dhiren and Dr. Anil in the panel, there are a lot of things which can be done in intensive care setting using inotropes, fluids, changing the heart rates this way, that way, changing the pH. But I think I would like to focus more on chronic heart failure, where we would like to treat them with other medications. When it comes to ADHF, we think whether there is hypotension or congestion. Based on whether they are present or not present, we treat them. If there is congestion, we want to reduce the volume. If there is dehydration, we want to give the volume. Like in this case, where there is no congestion and patient is hypoperfused, then you give fluid and see whether the patient is responding. But for today, I would like to focus on chronic heart failure. Now, coming to heart failure in children, these are the drugs which we use. This is a very important slide. I would like you to spend 10-15 seconds over here, because these are the drugs which are often used in OPD practice, and patients are mostly on these drugs even when they are being seen by cardiologists. So we need to understand when to give, when not to give, what may be preferred, what may not be preferred. So diuretics are only for symptomatic management. ACE inhibitor, beta blocker, and aldosterone antagonist, all three are important drugs, and they are to be given in all patients with heart failure. ACE inhibitor is to be given even if the patient is having no symptoms. So as you can see, ACE inhibitor is the drug which is given in patients with ventricular dysfunction even when they have no symptoms, because it has been shown to have reverse remodeling. Now, having said that, these drugs have very limited pediatric specific data, and we are taking almost everything from the adult populations. These are the four pillars of heart failure management. One is the ACE inhibitor, or ARB, or upcoming ARNI, or angiotensin neprilysin receptor antagonist, beta blockers, aldosterone antagonists, and SGLT2 inhibitors. Nowadays, you must have heard the names of dapagliflozin, empagliflozin, and these are the four pillars which are used in heart failure in adults. Now, ACE inhibitor and ARB are very potent agents which causes reverse remodeling, and that is why they are to be used in all patients of ventricular dysfunction, even if they are asymptomatic. It acts on RAS pathway. The major problem that can happen with them is hyperkalemia, especially in the patients who have compromised renal function, and therefore those patients needs more careful monitoring. However, after initial 1 week or so, these patients remain on stable renal function, and usually they do not cause any problem. There are no data on ARB in children. However, we have used it and it doesn't cause much of problem. Now, these are various trials that have shown in pediatric population, the effects have not been as good as in adults, but even then, it has been shown that it is effective. These are various trials which have shown that captopril, perindopril, and almost all others have shown benefits in pediatric heart failure. So ACE inhibitor should be used. Having said that, if the heart failure is because of single ventricle physiology, as it can happen in some of the conditions, then ACE inhibitor is not as much useful. However, we continue to use it because we don't have many other drugs to treat these patients. So this is class 1 indication. Symptomatic LV dysfunction should be given. Asymptomatic also should be given ACE inhibition. Now, these are some do's and don'ts about ACE inhibitor. Majority is hyperkalemia and renal dysfunction. It is contraindicated in patients with allergy and renal artery stenosis. Pregnancy, I'm sure you don't deal with, but if the patient is pregnant, then they should be contraindicated because it has a teratogenic effect. So before you start, check the renal function, start at low dose, and then do renal monitoring every few weeks. Once it is stabilized, then we can do every 2 weekly. I'll leave it for the time being. This is ARNI. This is new drug. I think there is a lot of hype around this drug. everywhere. It acts on two pathways. One is the RAS pathway, and there is a neprilysin inhibitor which actually degrades that. So there is a combination which actually make ACE. So this is, you can say this is super ACE inhibitor. So it gives much more effect of ACE remission, and it gives persistent results even after long duration. This was the trial which gave ARNI its place in heart failure management. And this was the trial that showed clearly that these patients can be, this drug can also be used in pediatric population. Although they did not show a lot of benefit, however, symptomatic benefits were there. And in current practice, this drug is being used in heart failure patients. So who are the patients who to be treated with ARNI? Those patients who can tolerate ACE inhibitor but are not controlled with heart failure can be started on ARNI. We have to use the same cautions like ACE inhibitor, renal function, electrolytes. The starting dose is 0.8 to 1.6 milligram per kg per day in infancy and 0.8 to 3.1 mg per kg per day in 2 divided doses beyond infancy. This is the beta blocker. When we were students, MBBS and in MD, we were told that beta blockers are contraindicated in heart failure. Even today, majority of us who are not working in cardiology units or have not seen cardiology practice close by, we think that the beta blocker may harm these patients. But it turns out that the beta blocker is rather a drug of choice in these patients, and multiple trials in adults have shown that beta blocker is safe and effective. The same has been shown in children, especially carvedilol. In adult population, metoprolol has been extensively used. In pediatric population, it is only the carvedilol. So we end up mostly using carvedilol. However, again, from our own experience, we can say that metoprolol is almost as good as carvedilol, and it is much cheaper and easily available. So it may be replaced, it may be given in place of carvedilol without any difficulty. Now, when it comes to Cochrane review, it says that there are no enough evidence to support or discourage. But if we go by the theory of the benefits, beta blocker is one of the drugs that should be started after ACE inhibitor. In adult heart failure practice, beta blocker is the first drug. In pediatric heart failure practice, possibly ACE inhibitor is the first drug and beta blocker is the second drug which should be started. Now, because of this lack of evidence, this still has a class 2A recommendation and should be given only in symptomatic patients. Those patients who are having acute decompensated heart failure, we have to start with caution after some time. Those patients who have asthma and second or third degree AV block, again, we have to use with caution. In high degree AV block, it is rather contraindicated. So I think time is running short, Neeraj. So I don't want to overstretch.
We can cover the main topics and we can skip few.
Okay. Okay. So this is spironolactone. Now, once the patient is in heart failure, if there is fluid overload, we also want to give them diuretic. Now, diuretic can be a furosemide-based diuretic or it can be spironolactone. Now, if the patient's renal function is okay, if you think that hyperkalemia is not such a big deal, or if we can monitor, these patients should be started on spironolactone because it has again shown to be having reverse remodeling effect on the myocardium. And these are specifically for patients with ventricular dysfunction. So we should prefer spironolactone over furosemide if these patients can tolerate without having renal dysfunction or hyperkalemia. Having said that, spironolactone is the drug which should be omitted first if the patient is having creatinine more than 1.5 in older children and more than 1.2 in infants. Now, this is new drug, which is dapagliflozin and empagliflozin. These drug increases the sugar and the fluid content of the urine, and that's how by causing diuresis, they improve the heart failure. Data in children is coming up. As of now, there is no established indication of giving dapagliflozin in children. However, in refractory cases, especially if it is RCM kind of condition, it may be given where nothing else can be working. There are some other drugs like diuretics. Now, it may be counterintuitive to a lot of you who are sitting here. The diuretic is the first drug which we give in patient with ventricular dysfunction, but why it is coming as other drugs? This is because diuretic does not have any mortality benefit. It does not change the natural history of the disease. What it does is only improves the symptoms. So it should be given only when there is fluid retention. Otherwise, diuretics may not be given. So a patient who is having ventricular dysfunction without any fluid overload, diuretics need not be given. They can be only on ACE inhibitor and beta blocker. Digoxin is again, there are no good data. It may be given in refractory cases. Ivabradine is another drug which is used in older children if the heart rate is not controlled despite giving good control of heart failure. Now, IVIG is something which is always contentious and it has to be discussed whenever it comes to ventricular dysfunction in children or heart failure in children. A patient comes with possible myocarditis. What do you do with such a child? So there are no good data, there are no randomized trial to support that IVIG benefits in recovery of ventricular dysfunction. As you can see over here, there are a lot of reports in the literature, but there are only 13 studies which could be analyzed in this meta-analysis. And they show, most of them you would show no difference in transplant survival, no difference in survival, no difference in recovery of LV ejection fraction. So as on today, IVIG in myocarditis has no specific role. Having said that, we still prefer IVIG even if it had doubtful benefits. If the patient is young, it is likely myocarditis, especially if it is short duration, less than 6 weeks. If there is rapid worsening course, if it is very severe ventricular dysfunction, like the ventricular function is less than 25 or 20%, and if there are positive cardiac markers like CROP-T and CPKMB, then we may give IVIG despite having no evidence towards that. Now, another question is, a patient was being followed up as ventricular dysfunction, possible myocarditis. Fortunately, with the natural history or otherwise, patient is improved. Now the ventricular function is normal. Now, when to stop medications? That is another question, probably that is more important for people who are seeing these patients in follow-up in your pediatrics OPD. And the answer is that you should not stop these medications immediately. Because once you stop these medications, there are chances that the ventricular dysfunction recurs. And it happens in routine practice also that the patient had recovery. Either the physician stopped medications or patient or the parents thought that let's stop the medication, it is returned normal. And they come back another 6 or 9 months later that these patients have ventricular dysfunction again. So what to do? You give at least for 2 years and then do stepwise reduction. Now, this is the last thing I want to emphasize for today's talk. This is PA banding. Sometimes a patient is having myocarditis or idiopathic ventricular dysfunction, is being treated with heart failure medications, but it is not improving as much. What do you do? In young children, considering the plasticity, considering the natural history of myocarditis and related diseases where the recovery may be there, PA band is another option, in which what is done is you band the pulmonary arteries and then you increase the right ventricular afterload. What happens with that is the right ventricular afterload increases, the septum shifts towards the left side, and that assists the left ventricle to pump the blood better into the aorta and to the body. And thereby, it improves the geometry and the hemodynamics of the heart, and thereby improving heart failure symptoms. It has been shown in this study that the PA band works quite well in those patients where there is isolated left ventricular dysfunction. What are the prerequisites? The right ventricle has to be normal, pulmonary artery pressure has to be normal, then only PA band can work. And it is so much effective in some of the cases that these patients could avoid heart transplantation or left ventricular assist device. So this is one treatment which is kind of underutilized currently in our country, and possibly in some cases which are refractory to medications, it may improve and may hasten the recovery of these patients.
Sorry to
Others are
interrupt.
devices. Sorry, yeah, Dr. Anil, I'm
Sorry
sorry.
to interrupt. Sir, we should wrap up in brief
Yes,
slides,
yes.
and we should take
Yeah, I'm
time
done
is
with it.
running.
Yeah, I'm done with it. So I'll not go into these details. These are very specific indications. And the last thing about the cardiac transplant, that the cardiac transplant is kind of evolving. With the improving techniques, cardiac transplant is one of the modalities by which pediatric heart failure can be treated. Now, in this forum, I think we cannot forget but to talk about diet, which should be energy dense and fluid conscious, vaccination, which should include influenza and other viruses, iron supplementation, vitamin D, and calcium. So, to conclude, pediatric heart failure is a heterogeneous group. Identifying etiology is more than half the job done. Limited data is there for the drugs. However, most of the principles can be adopted from adult studies. Diuretics, ACE inhibitor, beta blockers are well tolerated. ACE inhibitor and beta blocker are the drug which should be preferred, especially if the patient is having no fluid overload. And medication should not be stopped immediately after recovery of LV function in a patient with previous LV dysfunction. Thank you so much for patient hearing. And
there are two questions there. So
Okay.
one is normal anti and pro-BNP levels in neonates and pediatric age group. Dr. Saurabh, do you have any comments on that?
so I think there are no specific cutoffs. We continue to follow the same numbers. So I think it is 125. Or so practical purposes, if it is more than 100, you start thinking about that this may be indicative of elevated BNP levels.
So these levels are different for acute failure or for compulsory failure, or you follow similar pattern?
It is considered the same for chronic heart failure. For those who have had elevated BNP, it is the trend which is more important than the actual number. So somebody who has had a BNP of say 5,000, if it is coming down to 1,000, I think we will consider it as a benefit and the success. On the other hand, in a patient who was normal, a BNP of 150 also would be abnormal.
So there is one more question. False positive, high troponin, high BNP, is it possible?
So troponin is related to the renal, it has a renal, connection. So if there is renal dysfunction, these patients may have troponin elevation, which may be falsely positive.
So thank you, sir, for this wonderful talk. And as a pediatrician in the ICU, we keep struggling how to differentiate myocarditis from DCM. And Mridul and me always keep thinking when to say DCM versus myocarditis. A lot of time we go by the history and by TROP-I, CPKMB, but you're right, we end up giving IVIG whenever we're in doubt. What is your take on this?
So I think we have to have a very pragmatic approach about it. There is no single investigation that can differentiate. And that is a problem in all these patients. So if echo is not giving any clues towards genetic or structural cardiomyopathy, then myocarditis becomes a significant possibility. Then duration of illness, I would consider anything less than 2 months should be considered as myocarditis until proved otherwise, because our aim is to give maximum benefit to the patient in terms of treatment. Now, in that, if the troponin is elevated, if there are STT changes, if CPK is elevated, I will assume it to be myocarditis and I will treat as if it is myocarditis without waiting for any further confirmation. In ECG, QTC is a non-specific marker that may be there in non-myocardial situations. So I will not rate it as much as STT changes and TROP-T elevation or CPKMB elevation.
So do you do MRI also to differentiate these cases? Like, do you do it frequently or infrequently? Yeah.
We do, but I think the yield of MRI is not great. And the amount of money and efforts we spend, the yield is not as much. So I'm not a great fan of doing myocarditis. I would like to take clinical decisions and treat these patients. One more thing I wanted to highlight here is if the patient has bundle branch abnormality or conduction abnormality, think about myocarditis. So we have seen that some of the inflammatory myocarditis, there can be left bundle branch block pattern, or there is non-specific IV conduction abnormality. In those cases, again, myocarditis is the higher possibility.
Thank you, Dr.
So one more,
Saurabh. It was really, yesterday night I was cursing Neeraj that kahan phasa raha hai Sunday ko, but your presentation was not only clear, concise, straightforward, just uncluttered and it's comprehensive. It was totally meant for pediatricians, pediatric intensivists who are not in very hardcore congenital heart disease, and take-home messages were perfect. And you talked about evabredin, and nowadays even in septic shock with tachycardia in adolescent it can be used. You talk about SGLT2 inhibitors, right? These are some latest things which I think we should know that. And the role of carvedilol, we know for so many years that it is being used, but other than carvedilol also. And my favorite question means, which was I was about to ask differentiation between cardiomyopathy and myocarditis, and it sometimes is difficult.
Yes.
Sometimes on acute cardiomyopathy, patient can have acute myocarditis also, can have infarction and leading to troponin high. But I will say it was wonderful talk, and start of the Sunday is a wonderful.
Thank you, sir. Sir, since you brought back the carvedilol, through this forum, I would like to just urge all the people listening over here that we underutilize beta blocker. We give very little doses, and children tolerate these doses very well. So every few weeks, these patients can be stepped up. Definitely, if a cardiologist is there, they can do a better job. But if the patient is not able to reach them, please do it on our behalf, because ultimate goal is to treat the patients. You treat or we treat, it is the same thing.
One more thing came to my mind, Dr. Saurabh.
Yeah.
You know, when I was in AIMS in 2004-5, we used to say levosimendan once a week for DCM patient. We were giving in those days also. People used to come on Sunday morning. We used to give levosimendan for 24 hours for those who are waiting for the transplant or something. Do you still do this nowadays?
No, we don't do one, because availability is an issue. Number two, I think the world over understanding about levosimendan has changed. I think you can just tide over time. But if such a situation arises, then I think the patient is a candidate for ventricular assist device rather than levosimendan. We probably are fooling ourselves and the patients if we are giving levosimendan like that. I mean, that is a very blunt and honest answer I can give.
Yes.
So it's sort of ventricular assist device. Definitely, sometimes you don't have a choice, you keep giving it. But I don't agree with that.
Yeah, obviously. Sure.
Sir, it was a very excellent and comprehensive presentation. So I would like to ask one question about IVIG.
Yeah.
So as we have discussed in subacute cases, subacute presentation, so where there are soft markers of inflammation is there, we still give IVIG in this. And after how long from the trigger of suspected myocarditis, we can think of giving IVIG?
So as I said, there are no recommendations because there are no good data. What we follow, and I think that is a pragmatic approach also. A patient symptomatic for less than 6 weeks or maybe 2 months at best, very severe ventricular dysfunction where the risk of the disease is much higher. When it is rapid worsening, where it may be a kind of inflammatory myocarditis, I would like to give. On the other hand, if the patient's EF is say 35%, 40%, history is like 3 months, I would say that, okay, other medications are going to help the patient, and I would not like to give IVIG.
So one more question about, I come from the intensive care background. It's related to like a patient with having bad lungs or ARDS. So we often overlook the right ventricular in patient with ARDS. So the patient usually sometimes have right ventricular dysfunction, and recently we have seen patient with influenza pneumonia. So in
Right.
some of these patients, nitric oxide help actually in improving their situation.
Right.
So what is your experience about right ventricular dysfunction in these patients?
So I think this becomes a very challenging situation. And here, nitric oxide and maybe sildenafil, they probably nitric oxide will help much more than sildenafil because nitric oxide has no effect localized to RV or PA. It also has effects on the peripheral vasculature in the lung. So probably it assists in both the gas exchange as well as vasodilation. So if we have to treat, then NO should be the first drug. Sildenafil may be used, but I feel that sildenafil has localized action to the central pulmonary arteries, and therefore the effects are not as great. Especially when you give NO, probably your ventilation is also better. So I think both ways it
Yeah,
helps. It's
Dr.
not only
Saurabh,
the
yes,
Yeah,
I
Dhiren
just
sir,
want to elaborate this question. What Anil wants to say that there were some few patients where we could not recruit the lung.
yeah.
Normally in ARDS, we say that recruit the lung, that your pulmonary vascular resistance will go down and patient will improve, right? So
Right.
for so many years, we used to have concept that INO doesn't play major role. In ARDS, you have to recruit the lung primarily.
Right.
But in few of the patients, when we were pushed towards the corner and we didn't anything, saturation was 50, 60, hovering around, and family refused for ECMO. And in this situation, we thought that, okay, let's give a trial of INO, and there was drastic improvement. And so we could not find the cause why it improved.
So
Means
actually,
alone,
yeah.
yeah.
So NO actually addresses the VQ mismatch. So even the areas which are, when there is perfusion ventilation mismatch, the NO works much better compared to any other pulmonary vasodilator. And probably that is the mechanism why it helps in even lung conditions. So even with the same amount of recruited lung, it maximizes their capacity to do the gas exchange.
So it goes into the areas or only on well ventilated areas.
Possibly, yeah.
Thank
But
you,
I
sir.
think that is slightly a different area. It's very complex, actually. Pulmonary related pH and acute decompensation, I would say.
Yeah, but we see, yes, sir.
Yeah, I know.
Pankaj sir.
I think if we are finished with the talk, and I think we are already over time, and
Pankaj
it
sir.
was too good talk, and
No,
means you
I'm
can
sorry.
continue
I
to
had
have
a
questions. It's not your fault. Your talk was so simple. We were interrupting in between, and
no,
almost
no,
10.
sir. Actually, when I get people to listen, I think that let me tell this also, let me tell that also. So I stretch little more than what I should possibly, but I hope it was okay.
You are real true teacher, sir.
Thank you. Thank you, Dr. Saurabh. We'll take one
Thank
more
you, sir.
pass from you soon. We'll take one more pass
Okay.
from you soon. Pankaj sir.
Thank you so much, Dr. Saurabh, and it was an excellent talk. And I've seen that you are very fond of teaching, so your very involvement in the talk was too impressive. And I congratulate you for your oratory skills, which are par excellence. And thanks to Dr. Dhiren and Dr. Anil for nicely moderating the session. Dhiren is an asset to us wherever he goes. Whatever he says is very, very interesting, and we all love that. And also thanks to Dr. Mridul, Dr. Neeraj for making it possible for us to help this pre-master class. So thanks to Dr. Smita, Dr. Dinesh Goyal, our joint secretary and president, is also joined. So I request Dr. Dinesh Goyal to present vote of thanks and for a few words. Dr. Dinesh Goyal, please. You are on mute, Dr. Dinesh. Mute pe ho aap.
I think before Dr.
Good morning
Goyal says one comment for Dr. Meena, he has left. He was looking like a model today.
Good morning, everyone. And this was a wonderful session by Dr. Saurabh on ventricular dysfunction in a child. And thanks to the chairperson, Dr. Anil Kumar and Dr. Dhiren Gupta, sir, our mentors. And this is a wonderful session, and it makes us to aware about these dysfunctions and how to deal them and when the cardiologist need is there. So I think for everyone, it is very good to have such sessions, and in future also we will have more sessions like this. And this is going a wonderful e-cardio classes. And I think if someone attend the all classes, so definitely the knowledge is increased much. And with this, thank you so much. And on the behalf of IIP Delhi, and thank you, Dr. Pankaj sir, thank you, Dr. Meena, and thank you, everyone.
Look forward to all of you for next Sunday again for another interesting session. Over to you. Thank you so much. Bye.
Thank you. Bye-bye. Bye-bye.
Thank you, sir.